many patients, but one particular patient comes into mind, and anybody who has this solution probably will have a similar story. I was on call. This is not too long ago, and patient came in with a significant amount of chest pain, shortness of breath, tachycardia, kind of the classic symptoms for a pulmonary embolism. But of course, in the ER, they don't know that that's what's going on, right? They get a chest X-ray usually, and then they'll get a CT scan driven by the symptoms. And nobody in the hospital, nobody on the planet knows that the patient may or may not have a pulmonary embolism at that point. It's still an unknown. Busy service, scans get done and patient gets scanned and they're sitting in the waiting room of the hospital. They're not even in a bed, and I get an alert, pulmonary embolism. And not only that, our pulmonary embolism protocols are driven by, as are all of your protocols, right? RV-LV ratio and the presence of thrombus. RV-LV ratio was severe. I think it was closer to 2 by calculations, automated calculations. And the thrombus amount, immediately pull up on my phone, very clearly a significant amount of thrombus. So we quickly mobilize in that context, right? Even before, usually the radiologist will call me and say, hey, I found this, and then the ER doctor will call me. But as I said, sometimes in these situations, the workflow is now different. It's almost the other way. It's now flowing from IR as opposed to IR. Reach out to the doctor taking care of the patient, let them know what I see, make sure we get them back quickly for intervention. And that we call it the death spiral of pulmonary embolism. For those of us who do this frequently, where patients' right hearts are failing and they can get very sick very rapidly. And this patient was such a patient. So we were able to get them back quickly for intervention, perform pulmonary artery thrombectomy, and then I think they went home like a day or two later. This is the type of patient, I'm not going to get into nitty gritty, but as things progressed during their short stay, before we got them to the lab for intervention, they started decompensating. And if I wonder, right, if not for this solution showing me potentially saving between 30 minutes, maybe even an hour of time as things are getting worked out, diagnoses are being made, would that patient have potentially succumbed to this pulmonary embolism? And I guarantee you that if we ran this scenario 10 times, some of those patients wouldn't have made it. But thanks to the software, thanks to the integrations, thanks to the fact that I'm getting these on my phone and I'm looking, right? I've been sort of, it's inculcated in me to, I see an RV-LV, that's bad. Okay, I'm looking at the pictures immediately. And it's become just part of my life. That patient is alive. So think about your family member coming to the ER with that kind of same story. Do you want to be at a hospital that has a doc that's going to tell you, there's a significant PE, the IR doctor is going to know right away, or the vascular surgeon or the cardiologist, whoever's running that service, they're going to know right away? Or do you want to go to one without? I think the answer is very clear.